I'd like to introduce our two speakers today, Dr. Corey Gill. Dr. Corey Gill did his medical school and residency at Washington University, in which after that he came to Texas Scottish Rite for his pediatric orthopedic fellowship in 2012. After having an extremely successful career, early career in pediatric orthopedics, we recruited him back and he joined us in 2018, primarily here on the Frisco campus. His professional interests are fracture care, clubfoot, hip dysplasia, as well as limb differences in youth athletes. Our second talk today is from Taylor Morrison, who's a certified sports dietitian. She received her bachelor's in nutritional science at TCU, and then got her master's in clinical nutrition at Memphis University. She, as a prior figure skater, competitive figure skater, as well as a cross-country runner, she knows how to talk to youth athletes. I really enjoy following her Instagram page, and she gives lots of great tips on recipes and things for kids as well. So you're going to hear from both of them today, and I'd like to start off with Dr. Gill. Dr. Gill?
Good morning, everyone. All right. So today we're going to talk about, from my standpoint, some musculoskeletal conditions, concerns in overweight and obese young athletes. I don't have any financial disclosures. And here's the list of some of our objectives for CME in describing musculoskeletal pathology associated with obesity in young athletes, interpreting these findings, and identifying some key clinical features of common musculoskeletal conditions in these young athletes. So, you might be thinking, why is obesity or being overweight an issue in pediatric sports medicine? These are athletes, they're very fit. They're probably not, overweight or obese. This is an issue of kind of sedentary kids that are just sitting on the couch and not playing sports. But that's an inaccurate. So, there's been several studies out there, and kids who are overweight or obese seem to participate in sports with the same frequency as normal weight children. And anecdotally, we all see as pediatric orthopedic surgeons, and I'm sure all of you as pediatricians or athletic trainers or other healthcare providers are seeing kids like this all the time. This is obviously an extreme example of a kid that's in 8th grade and 6'7", 370 pounds, but it happens, and we see big kids like this all the time, and is why I'm happy my 85-pound 13-year-old has decided not to play football for the time being. So, but we also know that overweight children who participate in sports are at higher risk of developing certain orthopedic injuries and or other conditions that can really affect their quality of life, and so oftentimes need surgery or lead to long-term sequelae. And so it's important that we kind of are aware of these things and know about them. Just as an overview, I'm going to talk a little bit about epidemiology. We're going to talk specifically about fractures and other injuries that can occur in sports and sport-type activities. We're going to talk about two very kind of specific conditions that we see in pediatric orthopedics: slip capital femoral epiphysis, or SCFE for short, and tibia vera, which is Blount disease. And these are two conditions that can really cause some significant problems and are definitely more common in kids who are overweight or obese. We're going to talk a little bit about kind of some of the perioperative concerns in these patients when they do need a surgery. Going to kind of intersperse some case examples throughout and talk about maybe some potential solutions. So in terms of epidemiology, just in terms of definitions, according to the CDC, you can see this table on the right, kids who are underweight are less than the 5th percentile BMI for age. Normal weight is the 5th to 85th. Overweight is 85th to 95th. Obese is 95th or greater. And there's another category, which is severe obesity, which usually falls kind of right at, one way to think about it is greater than 99th percentile. Technically, it's 120% of the 95th percentile. But as you'll see here in a little bit, that's actually a fairly large percentage of the kids that we see. And, compared to 50 years ago, there definitely seems to be more overweight and obese kids. And currently, and this is, obviously a few years in the past, but It's up to, the CDC says 16.9% of children are obese, and 32% are considered overweight. And here's just a different way to look at this. Texas is, kind of in the middle a little bit. We're not as bad as Mississippi and my home state, Georgia, but we're definitely higher than some other states. And, again, anecdotally, we all see and we all know that there are a lot of kids that are fairly big here that we see as patients. This is from a few years ago. I decided to just look at all of my cases over about a year, just because I was curious, and anecdotally I was seeing kids all the time, and it seemed like almost all the cases I was doing were kids that were quite large. And this is just, again, an N of one of just myself, but you can see that of the surgeries I did in 2018, 36% were obese. And that definitely is higher than what you would expect for the typical school-age child in Texas, which would be about 15%. And if you look at even further, almost a quarter of the patients I am operating on are greater than the 99th percentile BMI for age. So this is, definitely a big deal in my practice, and I'm not the exception, within, I think, my partners in my group, or, around the state or around the country. I think this is what we're all kind of seeing. And there are a lot of kids that aren't just a little bit, big. They're really, really, really big, and that leads to, a lot of the problems that are causing them to need surgery. So the next thing I'm going to talk about is kind of fractures and other injuries, with traumatic injuries. And we know there's definitely, multiple articles, multiple information out in the scientific literature that we know fractures and orthopedic injuries are more common in overweight and obese children. And that's been found, in both upper extremity injuries, lower extremity injuries. When obese children, you can see in this top article here, there are often, or can actually be more likely to have severe consequences from their injuries too. In this example, they're more likely to die from their traumatic injuries and these kind of severe trauma. So we know it's more common in these big kids. And we often see that these injuries are more complex. And that's been shown in both the pediatric literature and the adult literature, upper extremity and lower extremity. You'll see on this next slide here, pediatric supracondylar humerus fractures, which is the most common. This is a type of elbow fracture we see in kids. It's the most common fracture that needs a surgery to fix it. And this study looked at kids and their size compared to the severity of their injury. And for those who aren't familiar, so the type 2 fractures tend to be pretty straightforward and easy to fix. The type 3 fractures need a surgery and oftentimes can be much more difficult to fix, much more technically demanding in the operating room, more likely to have nerve injuries or blood vessel injuries. And you can see here that in the obese kind of cohort, they're much more likely to have these kind of complex, type 3 injuries than their normal weight peers. And this is kind of shown again and again in different parts of the body. Distal radius fractures, kind of a direct correlation between BMI and, complexity of the fracture. And this kind of makes sense, right? I think it's physics. If you're a big kid and you weigh more and you have an injury, there's just more energy there because you're a bigger kid. It's just physics. And then especially when you kind of start putting gravity defying or, activities into the mix, then it really becomes much more difficult. So trampolines and, skateboards and, things that throw you up in the air, or trying to do parkour, all these different things that, just tend to make sense that it would make it more complex. So a couple case examples. This is a 10-year-old kid who was, driving an ATV. And anecdotally, with COVID times, we're also seeing many, many more ATV injuries as well. But this guy was, riding around on the ATV, no helmet. He's 10. He weighs 92 kilos. His BMI is 40. And this is, a picture of his injury. And we very often see kind of, distal forearm fractures, wrist fractures in kids. but they're usually not kind of blown apart like this. So this kid broke it right through the growth plate of the radius bone. He also broke the ulna bone. And this little piece right here is a big chunk that was out there. And when we did his surgery, that piece just kind of was free floating and not attached to anything. And that's his growth plate on the end of his radius bone. So that's not ideal for, a kid with an injury like this. And I think this is, in part the activity that he chose, but in large part the fact that he's a 200-pound, 10-year-old. And so these are more difficult to fix when we have to try and, put these things back together. And this kid fortunately did okay, but it definitely it can be a harder road and with more risk and more complications. So this is another kid who's 13 visiting in town, some cousins from Seattle, and decided he would try skateboarding for the first time. He's 129 kilos, and he fell and he got an open humerus fracture, which is also not the most common thing we see. And I think in large part was because of his size. Again, this is kind of the physics part of it. You take a kid that's 130 kilos and, skateboarding, and you have a big fall, there's more energy there. You're more likely to have a bigger injury. So, this doesn't require a little surgery to fix it either. You can see that, the big incision here, and, it takes a lot of metal to kind of put all that back together. Fortunately, this kid did well too, but this is not a small surgery. So, in addition to having more fractures, more injuries, more complex, we also know that kids that are overweight or obese tend to have to go to the operating room more often than their normal weight kind of peers. And I think that's just because of the soft tissue size. There's a lot of fractures in kids we can treat with casts and kind of molding a cast to hold everything in a good position. But if you're bigger, then you're more likely to kind of have the fracture move, and you fail kind of cast treatment to need to kind of go to the OR to then try and get things lined up well. And there's been multiple studies. These are all kind of in forearm fractures showing that if you're bigger, more likely to fail kind of non-surgical treatment. And here's another case. Sometimes we just see weird stuff. So this is a 10-year-old kid who is 88 kilos. And he said he fell in his room while he was studying. And then he had leg pain. He had pain for several days. He went to another emergency room and they sent him home. He went to then try and take the STAR test and he was still hurting. And then he kind of came into our emergency room, and you can kind of see this little kind of line on the x-ray there. This is what the kid's leg looked like. And he said, did you fall on anything? Did anything have happened? He's like, no. And what's this little kind of, scab right here? He's like, I'm not really sure. But I suspected there was something inside his leg, and we went to the operating room, and he had an entire pencil inside his leg, and he just fell, landed on the pencil, and this is obviously quite unusual, but I think in part was because of his size. It takes a lot of force to get an entire pencil inside your leg. All right, so another big condition, our next one that we're going to talk about, is slip capital femoral epiphysis. So SCFE for short. I would say this is one of the most, if not the most common hip problem requiring surgical treatment in adolescents. We see this very frequently, and it is often a condition that can be easily missed because the kids sometimes don't come in complaining of hip pain. They don't have a clear injury per se, but oftentimes they're athletes and they're playing football or soccer or whatever they're doing, and they're saying, oh, maybe my hip hurts, or oftentimes they'll say my knee hurts. So I think this is a big finding that I would like to kind of reinforce all the pediatricians, trainers, anyone that's seeing kind of a youth athlete, especially if they're large, if they have an adolescent complaining of hip or knee pain, then you need to really think about SCFE as a potential cause of that. And you can kind of think about this like a stress fracture through the top of the femur bone, where the whole femoral epiphysis, the ball and the socket part of the hip, that it kind of has a stress fracture, and the rest of the neck and the shaft of the femur bone moves relative to that area. And the other way people describe it is kind of like an ice cream scoop falling off a cone. So if you kind of imagine the head is the ice cream scoop, it can fall off, and sometimes it just moves a little bit, which is still a problem, but sometimes it can move all the way off like this, which is what we call an unstable skiffy, which is defined by the fact that they can't really put weight on it at all, even with a crutch, and that is really like a hip fracture in an adult, and much higher risk of problems like problems with the blood supply, avascular necrosis, other issues if they have an unstable skiffy. And skiffies are definitely associated with obesity and being overweight. So most of these kids are overweight or obese. And this study found that only 4.7% of kids with skiffies were normal weight. The rest were overweight or obese. And so actually, if we see a kid that has a skiffy that's a normal size, we think about other things like endocrine problems. So this is really primarily a problem that we only see in kids that are big. And we know that it's kind of going up. So rate of skiffy is increasing over time. This is obviously, a bit in the past, and this was in the UK, where they found that the rate of skiffy kind of fairly closely correlated with the increasing size of kids over time. And I expect that this is, as kids continue to get bigger and bigger, that this is we're going to see this number to continue to go up and up. And as a case example of this is a 10-year-old female, 1 year of left thigh pain. So this is another important part of this. These are athletes that oftentimes they start to develop a skiffy, but it's not a complete fracture where it's unstable, and they're still trying to participate in sports. They're running around doing things. And if you can catch it early, the treatment is usually often a lot easier. Still, you have to watch out for things and they can have problems in the future, but by putting a screw in and with a very low likelihood of a problem with the blood supply to the bone. But if they continue to participate in sports, it's kind of like a ticking time bomb. And at some point, it may turn into an unstable skiffy and be a much bigger problem. So again, I would say definitely one of the take homes of this talk is if you have a youth athlete with hip pain, knee pain, they're overweight or obese. And the other thing to look out for is if they're walking with a limp, especially if their foot is turned out to the side, then, it's worth, a referral to an orthopedic doctor, or someone to check on whether they have a skiffy or not. This is a study out of Texas Scottish Rite, with the senior author being my previous partner, Dr. Carroll. And I thought this was really depressing, but also enlightening. And, I would say as a kind of a plea to all orthopedic surgeons, but also, pediatricians and everyone out there that's taking care of some of these kids. So this is looking at long-term 20-year follow-up of skiffy and the issues that they had as adults. Much higher rate of diabetes and hypertension than the national average. They continued to be obese or very obese into adulthood. But the shocking thing to me is that almost 10% of these kids were dead 20 years after their skiffy. And so these aren't like 80-year-olds, right? Like these are, 30-year-old, adults. And so, the natural history, and I'm not saying that they didn't die because of their skiffy, but, if kids are this big and they're having these kind of issues and they're still kids, anything we can do to kind of move the needle, to make them, better, has really dramatic long-term effects. So next, I'm going to talk about Blount disease. And similar to skiffy, we only see this, generally speaking, in kids that are quite large. And this is a growth deformity of the proximal tibia that ends up leading to bowed legs. Most commonly occurs in Black males. And almost all these kids are quite large, and not by a little bit. So the one study, the average Blount patient exceeded the 95th percentile by over 40 kilograms. So it's usually not subtle. These probably aren't, generally speaking, sprinters, but, definitely there's been multiple kids that have had this over the years that are high-level athletes, I think, including some kids who have gone on to have professional careers after this condition that we've seen in Scottish Rite, but it's something that can be a really big problem, lead to lots of long-term issues as well. And you can imagine if the leg is that bowed, that it's not great for the long-term health of the knee. and these are often very difficult to treat. So this is a 9-year-old who had leg deformity for a long time and now was starting to have knee pain. BMI was greater than the 99th percentile. Had treatment with what we what's called guided growth, where basically you tether one side of the growth plate to try and encourage the sick side of the growth plate over here to kind of gradually let the leg straighten back out. And this sometimes can work even when it's really bad. And I have some examples of that. But oftentimes it doesn't. These screws can break and have other issues. And if that's not working, then kids need a really big surgery. Like this kid with a similar story has a broken screw here. She's quite large for her age and height. And, oftentimes these kind of big, frames and gradual correction of their deformity has to occur. And this is one of my partners did this surgery. But basically you have to cut the bone and put this big external device on and gradually straighten the leg over a long period of time. And as you can imagine, this is not a small thing, and there can certainly be complications associated with this type of treatment. Fortunately, in this child, the leg was able to be straightened over time, but then she came back a few years later. Now her other leg is kind of bowed. So, this is something you have to continue to follow them over time. And she subsequently this wasn't quite as severe on this side. She had growth modulation surgery on the other side, which helped take care of the problem over there. But this is a really big problem as well. And, I think it is a difficult issue. And if someone has, novel ideas for solutions in terms of trying to help these people get to a healthier weight, I'm all ears, but it's difficult. Because these people usually don't, get smaller after this kind of life-altering diagnosis. They usually get bigger. So most kids, actually put on weight despite counseling and best efforts. And I know in the past, years ago, before I started, there were some kids that came to Scottish Rite as inpatients for months and months and months with a very controlled diet and kind of watching everything, and got smaller so they could then be treated for their Blount disease. And then, most of those kids, or all of those kids, I think, as soon as that was tried, they put on all the weight as soon as they left the hospital. So it's a difficult problem with not an easy solution, but still really important because of significant long-term consequences. And I expect that, similar to that long-term follow-up study of SCFEs and mortality, I expect it's probably even worse, in this group. And that's an area where some of my partners have tried to look into. It's quite difficult. So I don't know if we'll ever see that data, per se, but I expect it's a very similar, that they have high mortality rates, super high rates of cardiovascular disease, and diabetes, other issues as adults. So, again, in a lot of these kids, we do need to do surgery for their various conditions, and some of the things we need to think about when they have surgery. They're more likely to start off with comorbidities like hypertension or sleep apnea or diabetes. Even though they're kids, they can have these things. And they're more likely to have complications if you do need to do surgery on these athletes, and other children who are obese or overweight, going back to the OR, having wound problems, having infections, having anesthesia-related issues. This is looking at one study in kids with Blount disease regarding sleep apnea. So almost all of them had sleep apnea on a sleep study. So, if I have a kid with Blount disease that needs a surgery, I'm almost always having them do a sleep study before surgery, because it's not great for a 10-year-old to have sleep apnea already either. And in this study, close to half of them required a preoperative tonsillectomy and adenoidectomy before they were even considered for their knee surgery. So you have to kind of keep an eye out for that. Hypertension is quite high, and there's actually some theory by one of my pediatric orthopedic colleagues in another location that this may actually be partly causative of SCFE and tibia vera in some ways, because these kids have a quite high rate of hypertension, and it's even higher than you would expect in this study when they compared to age and matched controls from an obesity clinic that didn't have SCFE or tibia vera, much higher rate of hypertension. And I thought the really other interesting thing from this study is not only was hypertension identified in a lot of these patients, but in only one of 171 had they been previously diagnosed with hypertension. So 64% of these kids have it, and no one's really being diagnosed with it. So, so I think this is a concern too. If half or more of these kids are having clinically significant hypertension, then we need to kind of catch that. So I certainly get blood pressures in all my kids that that I've seen that have a Skippy or Blount disease. And, I would encourage those, seeing them outside of an orthopedic setting to, think about their blood pressure as an issue as well. Definitely, can have higher risk of complications or adverse outcomes and some of these things like infection, return to the OR. And this has been shown kind of time and again in various patient groups. And hip dysplasia and femur fractures, all of these have higher rates of complications and issues compared in overweight or obese kids compared to normal weight peers. Here is another case example. This is a 12-year-old kid. He's quite large. He has a relatively, really pretty straightforward fracture that just needs to kind of be pushed into a better position and held in a cast, which was done. But because of his size, he required emergent reintubation in the OR, at the end of the case, and developed pulmonary edema and ended up having to stay in the hospital overnight for, something that is really a very straightforward procedure to try and deal with a straightforward fracture. So you definitely have to keep your guard up at all times, even if it's a relatively straightforward case. Our anesthesiologist here, Scott Schreider, amazing. But this is definitely one of their concerns. If a kid is quite large, then they have to kind of prepare for the case and do things a little bit differently because of these higher rates of complications and issues. So what can we do? Excuse me, about this problem, so that kids aren't having more issues than you would expect compared to their normal weight peers, and are able to participate in sports and do all the things that they love, and it's not an easy solution. We'll touch on a couple of the things. My colleague is going to talk about nutrition here in more detail here in a second, so I'll kind of move through that very quickly and talk about some of these other things like actually playing sports, and is that helpful, surgery, and some other kind of modalities. So again, I won't touch much on nutrition, but this I thought was just interesting in one study showing that a lot of the stories we hear when they come in are like, they exercise, it's just that I don't know why they don't really eat very much, but that's not really the case. If you look at mathematical models, in order for the kids to be as large as they are, most of them on average are consuming kind of more than 1,000 calories a day, more than their peers, to be able to kind of maintain and stay at that increased size. And so, we need to kind of go from this diet, and not, joking, multiple times I've seen less than 2-year-olds come in with Sonic slushies earlier than, 9:30 in the morning to clinic. So, it happens, to something that's a little bit healthier diet. Sports, I think, is great for kids. And as we showed at the beginning, these kids do seem to participate in sports, and we definitely have some kids that don't do that. But a lot of them do already, and that should be encouraged. And we want them to kind of keep doing those things. There's the literature is mixed in terms of whether this actually helps kids lose weight or not, or get to a healthier size. But there are at least, a couple studies like this trial here where they randomize kids to an after-school soccer program versus kind of education only. And the kids that were participating in this activity had significantly, better decreases in their BMI, both in the short and medium term, and significant kind of sustained increases in their activity levels down the road. So, I definitely think that sports is a great thing for these kids, but we also don't want them to be developing, injuries and other things more than often. So, I wouldn't pick, necessarily gymnastics for someone that's, in the greater than 99th percentile BMI for age, but we definitely want them doing activities. Surgery, obviously this seems pretty drastic to do a surgery for being obese or overweight. And there's not that many that are done on adolescents each year in the US, but I think this is something that we have to kind of think about. And in some people, I think this is the right decision. There's a relatively high complication rate, but of all the things out there, especially, in an older adolescent, this is the most effective thing for obtaining and maintaining weight loss. And in this study out of the New England Journal, there were some complications or issues in kids that had bariatric surgery, but they lost an average of 27% of their weight. Their quality of life improved significantly. And their rates of diabetes, high blood pressure, lipid issues all got significantly better. So, I think despite the risk, if you've got a kid that's, in the severe obesity category and a 16-year-old and they're not done well with other things, I think, I would certainly argue that the relatively small complication rate is the benefits outweigh the risk when you're looking at probably a 10-20% mortality potentially 20 years down the road. So in summary, obesity is very common, and I think it's getting more common. And I think anecdotally, at least in my practice with the pandemic over the last 1+ years, kids are getting kind of bigger and bigger, as some of you may have heard stories about or seeing in your own practices. Kids are active in sports, and a lot of times in high-level sports, even if they're overweight or obese. Fractures are much more common, more complex, and more likely to fail, kind of non-operative treatment. These other conditions that are to be aware of in overweight and obese athletes like SCFE and Blount disease are important to be aware of. It's important to know that they have other medical comorbidities that often need treatment, and that there's not an easy solution, but it's a big problem. So we all need to kind of get together and try and figure out innovative new solutions to try and move the needle on this. So with that, I'll leave it to my colleague Taylor here to talk a little bit more about the nutrition side of things. And we'll have a question and answer session at the end.
All right, thank you, Dr. Gill. Hi, everyone. I am excited to be here this morning to talk to you about what I feel is a pretty sensitive topic, and that is nutrition for the young athlete with overweight and obesity. Again, I'm Taylor Morrison. I'm a sports dietitian here with the Scottish Rite Sports Medicine team. I have nothing to disclose. I will say that there's so much to say on this topic, but I only have about 15 minutes. So what I'm going to do today is talk about some of the complexities of weight management and nutrition for young athletes with overweight and obesity. I want to do a brief literature review, what studies are showing is not successful for weight management, and then what research is finding are promising methods for weight management for this population. I want to go through a case study for some practical application and leave you with a few takeaways. By the end of my brief time with you this morning, I hope that you're more knowledgeable of the recent literature regarding nutrition for weight management, that you understand why making diet changes can be difficult for the young athlete and the risks involved, and that you feel more confident supporting young athletes with obesity and achieving long-term weight and health goals. So I think we all know the basic recommendations for nutrition for weight management, and that's increase our intake of fruits and vegetables, decrease our saturated fats and our fried foods, our sugary drinks. But I think it could be argued that if that's all it was, then we could all be about the same size. We wouldn't have such a big diet industry. I probably wouldn't be here talking to you this morning. And so we need to realize that the reality, as Dr. Gill just suggested, is that weight management is very complicated. There is so much going on with weight management. So many things contribute to our size and our weight and our body type and structure. It is a complex makeup. It's psychological, it's genetic, it's behavioral, it's environmental, it's cultural. There are so many factors that contribute to what we eat, why we eat, how much we eat, and then how our bodies respond to what we eat. And so when we're working with our athletes, we just want to be aware that this is complex. It's often very time consuming. It can be very frustrating and very challenging for not only the person trying to make these changes, but for the whole support team. Not only is weight management difficult in general, but it can really have some added challenges for this population, especially when we start looking at teens and adolescents. And that's because of what's going on during this stage of growth and development. During this period, we know there's an increase in autonomy, there's an altered access to food, especially if the athlete is driving and they're going out and able to get their own food. They're eating with their friends. There's increased influence from peers and then a desire to be like their peers. We know if anyone's worked with teens or if you have a teen that they're more likely to skip meals, especially breakfast. They're more susceptible to fad diets and then trying supplements. They might make more impulsive decisions. And there's not quite that ability to comprehend future risks. So just telling a child or a teen athlete that, oh, well, this will help you prevent, this complication 30, 40 years down the road may not be the best approach for them. We also know that they have busy training, academic, and extracurricular schedules. And then I think we all know this applies to really everyone. Just being aware of the importance of nutrition does not always lead to action. So we need to be ready to support this athlete for the long term versus, one handout or one education session. It can also be a sensitive topic. We know that during childhood and adolescence, there's a rapid state of growth and development, which can lead to a preoccupation with body size and shape. No matter what the size and shape of that athlete is, which can lead to unhealthy weight control behaviors. And for our athletes, that can lead to decreases in strength and performance and changes in mood and some disordered eating behaviors. We also know that self-esteem goes up and down during adolescence. There can be an increased risk of low self-esteem, and that's actually increased for those with obesity. Low self-esteem has been linked to disordered eating, dieting, and again, preoccupation with body weight and shape. So this is just to be mindful that even the most well-intended comment could set an athlete on the road to some unhealthy eating behaviors. And so we just want to be mindful of how we approach the topic, when we approach the topic, and making sure that there's a good support team involved. Studies are showing that there's reason to be concerned that prevention and clinical efforts to decrease obesity that intentionally promote an eating disorder or some disordered eating. We know that disordered eating, if it's going to develop, it often does develop during adolescence, and children and teens with obesity are at an increased risk of this. And it's extremely important to realize that any kind of disordered eating can happen at any age and any body size. So an athlete is never too young to experience this. And we need to be aware that just because an athlete may not look like they have disordered eating going on, doesn't mean that they're not struggling with it internally. So I say that just as kind of something to be aware of. As we approach the topic, we just need to be mindful of all the different things that can be going on with the athlete that they may not be vocalizing to us in person. But going through the literature, there are some methods that have been effective for managing weight of the young athlete when they are ready, when it's appropriate. So that's what I want to quickly touch on. So first of all, just a quick slide on things are being found to be not successful, and that are really these fad quick fix diets. So low carb, low glycemic index, even they haven't found across the board success with high protein diets, these extreme calorie restricted diets. And I say not successful because most of the literature is finding that these can cause weight loss short term, but they're either, not long term, like they gain it back within a year, or they gain it back and then more, or one of these methods puts their growth, development, or mental health at risk. But there are several approaches that are showing promise, and I want to touch on those now. First is really, they're calling it a non-diet approach, and this emphasizes low-fat foods, so low energy density foods. It encourages nutrient-dense foods, so again, the fruits and the vegetables, whole grains, low-fat dairy, and it emphasizes moderate portions, but not prescribing not a specific calorie prescription. Now, you may know this behind the scenes. So like me as the dietitian, I know the calories, I know carbs and protein and fat, but this isn't what I'm talking necessarily to my athlete about. I'm not having this child or this teenager count calories and keeping track of their grams of protein. There have been several studies done with this approach that have seen improvements in weight and BMI Z-scores. I did think it was interesting that they did the non-diet approach versus a group that used a structured meal plan. And they found that the group with the structured meal plan actually was discontinued because they had an 83% dropout rate. And so we know that for anything to be effective, it must be sustainable. And so this is suggesting that something super rigid for our teenagers or our children may not be the best approach just because it may not be sustainable for them. And this approach focuses on the positive, what should be eaten versus all the things that should not be eaten. The second approach is this modified stoplight for children. This is another less restrictive approach. And what it does is it groups foods according to nutrient density and calorie density. So what that means here in the green category, kind of your go food, these are high nutrient dense foods, high nutrient dense, low calorie dense. So again, your fruits, your vegetables, legumes, low fat milk, lean meats, or, lean meat substitutes for those that don't eat meat. And as we get into yellow and red, that reverses. So we get low nutrient dense, high calorie dense foods. And those are the red foods, which we want to eat less often. And it doesn't mean that we're taking these foods off the table completely. It just means that we don't want these foods in the red to outshine the foods in the green, because these are the ones that we need the most. And this approach, again, is emphasizing these healthier foods, so the foods in the green. It showed improvement in weight status, and the weight was sustained longer term, which for this was about 6 months to 2 years. What I thought was interesting here and should be pointed out is that the improvements in weight correlated with less parental restriction over the child's eating patterns and less concerns about the child's weight. So the parents and the family are involved because that's crucial. Every review I've looked at talks about the importance of parents and family being in on this with the child or the teenager, but there wasn't as much hovering and really watching every move they make. They're letting the child or the teenager have a little bit of autonomy within this. And the third approach is something called intuitive eating, which some of you may have heard of as well. And this is an approach that focuses on eating motivated by physical reasons. So it's trying to block out the external reasons that we may eat and really look at the internal reasons. So looking at one's internal hunger and satiety. It has been associated with a lower BMI and cardiovascular risk and improved psychological health, and it's suggested to have benefits in disordered eating behaviors. So this is really helpful if you feel like you're working with someone who may have some unhealthy eating behaviors going on. This may be a first step. So those are 3 of the studies showing promise. And now I want to go through a quick case study with you guys and talk through a patient and family that I worked with recently. So this was a 14-year-old female, and she came to me for weight management. The family and the patient wanted help with managing her weight. There had been recent unintentional weight gain, and so this growth chart is her BMI for age. So this is showing BMI. And this is showing, I would say she's averaging around the 70th or 75th percentile right here. And there had just been suddenly an increase in her weight and BMI, and the parents were extremely concerned. And so brought her in to see me. I looked at the growth chart before meeting with them. And then in our initial visit, really wanted to get to know the family, the patient, what's going on. Because to me, the concern more was the unintentional sudden weight gain. And as I talked to this patient, she had already gone through her growth spurt. That had, this was not associated with an increase in height. So we talked with the family. There was a lot of restriction in the home. The patient felt very different at school. She couldn't bring the kind of lunches that her friends were bringing, fancy, shrimp or chicken or salmon with asparagus and just healthy foods, but not what her friends and peers were eating. I noticed that there seemed to be feelings of shame associated with eating certain foods. I had her go through a food journal, a diet history, and when she would say certain foods that she felt were off limits, she would look down, look away, get very quiet, and would not look me in the eye. This happened frequently. There were a lot of off-limits foods. We realized some suspected binge eating and eating in secrecy. And there was forced exercise. So she was, making herself trip elliptical, treadmill, just doing machines that she didn't enjoy. And this was on top of a sport. So she was doing a sport as well. So for this particular patient, I felt that the intuitive eating approach might be the best way to start because there was so much anxiety around food. There was a potential, some disordered eating going on. And if I had told this patient, we need to increase your fruit and vegetable consumption and you can't have that, I think she wouldn't have come back because that was what was being told to her all the time. And you could just tell she was tuning it out. And so instead, what I decided to do was start to normalize foods a little bit. And I talked to mom privately and I asked her to, if the patient loves this one kind of cookie or ice cream, let's allow that. And so we normalized, we allowed foods, we removed some black and white thinking. I talked with the athlete about, what lunch would you like to take? What would you like to take? And, she just wanted a simple peanut butter and jelly sandwich and an apple. And, there's nothing wrong with that. Or a turkey sandwich. She just wanted something in a brown bag and there's nothing wrong with that. We talked about finding fun exercises, something that she would enjoy doing outside of her sport, and then finding healthy ways of coping. So we did talk about ways of coping without using food. And I used this intuitive eating workbook for teens, which I actually did purchase a copy myself just to look through, to see, to walk through it and see what it was about. I worked with this family for a year. So again, it takes time and you need to be patient. But this family, I worked with them a year. We met about monthly and mom and dad continued to bring the patient back. I did some talks with the family. I did some one-on-ones with the athlete. And they both felt they decided to get this book. Mom and dad felt it was actually very helpful for them. And they gave the patient a little bit more autonomy in what she wanted to have for lunches or dinners one night a week. And by the end of our time together, which again, this took about a year, there were our final visit, much higher spirits. She was doing exercises on top of her sport that she enjoyed. She was inviting friends, family to join her. There was so much less anxiety about food. She would talk to me about meals and make eye contact with me. There was no changes in voice or looking away or hesitation. And both the parents said that they noticed they stopped seeing these disordered eating behaviors. And I noticed that over time, her BMI started to fall again down to below the 85th, more to where she seemed to be trending at her normal trend, which was kind of around the 75th. And so that is just one example of kind of outside the box, just things that could be going on. Another way we could approach weight management and nutrition for these children and teens and young athletes. I will say that if this patient's BMI had always trended, between the 85th here and 90th, then I would have approached this differently. But because of everything going on and that what I found out the initial session, this is how we decided to approach food and nutrition for this patient and family. And just one last slide, because I do see this also, the athlete with a high weight goal. What do we do when, the athlete wants to be a very high weight because maybe they need it for their sport? A lot of times we get this with football players. But what I would encourage there, we want to encourage building lean muscle. We want to be strategic with our increased intake. We want to make sure we're increasing energy density or calories, but also nutrient density. And I actually wrote an article about this, and it's on the sports medicine page of the Scottish Rite website. The link is below, but you can also search weight gain for the athlete or bulking up, and you should find it. So in summary, a few takeaways. What can you do when you're working with your athletes after today? You have an athlete that you feel like really would benefit from weight management, or they've been struggling with their weight maybe during this pandemic. There's been anxiety, there's been an increase in weight. How can we approach this? How can we help our children and our teens? The first step would be assessing readiness. So as I said in the very beginning, ask the athlete, what are their goals right now? We want to make sure those align with, any type of weight management. Let's look at their mental health. Is this a time of stress and anxiety, or are things pretty calm? I would say if life is very stressful, that's not the best time to work on weight management, because changing our weight in our body is stressful. What are their current eating practices in relationship with food? And looking at the family dynamics, because the family has to be on board and ready to model the behaviors that they want to see in their child and their teenager. And then family meals are big. Of course, when we have athletes and there's teenagers, it's really hard to get lots of family meals. But if you can make one a week or get something on the calendar to be eating as a family, that is extremely important. Once we feel the athlete is ready to make these changes and start with weight management practices, the big recommendations I would make are, first of all, starting in the off season. We know if we have athletes, any changes in our diet or trying to make body composition changes should be done away from high performance time. And that's to prevent any further injury. Want to make sure that they're eating 3 regular meals a day with quality snacks. We don't want these athletes to be hungry. We don't want kids and teens to be hungry, because we will eat. That's the body's natural response to hunger, is to eat. I put a picture here just to give an example with these athletes. Every meal, every snack counts. So this is just an example. You could have 2 handfuls of pretzels and you're getting 220 calories, but you're really not getting those things like protein, fiber, and fat that fill you up. Or you could have half a turkey sandwich with these ingredients right here. You get the same amount of energy, but you get 17 grams of protein, 4 grams of fiber, about 5 grams of fat, which helps increase satiety and build lean muscle. We want to increase these nutrient-dense foods, but not through restriction, more through the approaches I talked about, this non-diet stoplight approach, or using intuitive eating, allowing the child and teen to self-regulate. We want to make the healthiest choice the easiest choice as the parent, or if you're in charge of team meals. Let's make the healthiest choice available. And of course, continuing to monitor mental and physical health throughout the process. These are a few resources that I've used and that are out there. You can find them online. The links to these resources are right here. The one is for weight management. This plate-by-plate approach is very similar, but it doesn't use the word weight management if you feel that would be a problem for your athlete. And then, of course, the intuitive eating workbook, which I talked to you guys about earlier. So that is all I have for you this morning. I will now turn it over to Dr. Ellis.
Boy, that was fantastic. And I'm going to ask you guys if you could sit over there for some questions and answers. And we have just a little bit of time for some questions. And I'd first like to make a comment. Taylor, I think that was really impressive data and information. And I found a lot of what you're telling these teens would be helpful for us as well as parents of teens. So thank you for that. I'll have to review some of that for my own health and wellness. One of the comments, Dr. Gill, I was really impressed with how many patients you've operated on that are severely obese. And me, like I may see in my practice, and I think many pediatricians have seen in their practice is, we try to convince them to lose weight, and we try to convince them to see a nutritionist and to have healthy habits and do some exercise. But at what point do you just throw your hands in the air and you decide, well, these are too obese and they require considerations for a lap band or liposuction or some surgical procedure? At what point do you make a referral, or do you make that decision point in your practice?
Yeah, I would say I have a low threshold for referral. They have to be 14, I think, to even be, considered as, potentially having that. So if they're younger than that, there's not much you can do from that standpoint. But I have a very low threshold to refer them to at least consult with the bariatric surgery team, because that's been shown to be the most effective. And I do kind of feel like throwing up my hands in the air, because I would say of the many Skiffy and Blount kids I've seen over the years, I counsel every single one of them about the importance of, being to a healthier weight, and that their condition is directly related to their size. And the number of people that I have seen lose weight over those years counseling everyone, 0. I've yet to have one person lose weight and get to a smaller size to any significant weight. So it's really frustrating. But again, if these kids have not only morbidity risk, but mortality risk, 20 years down the road, I don't think it's something that we can just say, sorry, but I don't know the answer. I mean, I think, and my personal opinion is that it needs to start early with pediatricians, because there's been studies out there that show obese toddlers end up as obese adolescents and obese adults. And so if they're coming in, as a teenager and they're already, 100 plus kilos, then that's a long haul. So I think it's imperative, and I know probably just as hard for them, and I'm sure they have these conversations, but I think that we have to move the needle back then. And I don't know, Taylor, do you have any suggestions? You talked about, it's difficult for these families that are really buying in and having a long and willing to bring their kid every month. What do you do for the family where the kid is not showing any readiness? Both parents are obese. The 1-year-old comes in with a baby bottle filled with Coke. What do you do? Do you just say, the heck with it? There's nothing I could do. Whatever. I don't know. I think it's a difficult problem.
Probably takes as much counseling on the parent as it does on the child.
I would say so. For me, especially if it's a child. Now, if it's a teenager, I direct a lot of my education to the teen. But if it's a child, I really try to talk to the parents, and sometimes I'll give a follow-up call for things that I'm not talking about in clinic necessarily, or we'll talk before the visit or after the visit. But I do a lot of talking with the parent as well. And I agree, it starts early. So a lot of habits are set, and it just gets harder when the child becomes a teenager. But yeah, I agree. Trying and just constantly talking. But yeah, it's hard when you've got to have the family modeling the behavior and buying in and setting the example.
Well, Taylor, one of the questions that that I oftentimes get, and I know many physical therapists and athletic trainers, they spend a lot of time with athletes after an injury. And so, we always philosophically believe that your caloric intake should somehow equal your energy expenditure. But when you have an injury, you may have an athlete that is eating what they need for 2 to 4 hours of soccer per day, 5 to 6 days a week. And then they have a big injury. And then they are not doing that form of activity. Do you counsel, or what are your recommendations to talk to these athletes about how to limit their caloric intake once after their injury? Or do you have an algorithm that you go through to try to counsel them on that? Because it's they're used to eating a lot of calories, and then all of a sudden, they can't still have 5 scrambled eggs for breakfast. You know what I mean?
Yeah.
Do you have a thought on that?
So my take would be, again, not necessarily focusing on the weight, of course, like the weight aspect, like, oh, this could be a big issue with your weight, but more focusing on, let's talk about healing for injury. Now let's look at how we can eat to heal. Let's look at how we can support any PT sessions. If you're on crutches, that's another factor to consider. But going back through and, doing that history, and if they're still eating, the 4 eggs and just all the more food than may be needed at the moment, it's more saying, okay, well, let's take a look at what you were doing before in your your practice schedule, and let's take a look at now with your injury and asking him questions. Tell me how you feel. Tell me what's your hunger scale now versus when you were an athlete. Nutrition is still really important, but it's going to look different right now compared to when you were fueling for your sport. Now you're fueling for injury recovery, and that's going to look different. And so we're going to shift gears a little bit, and then and try to get you recovered. We're going to, work with PT, work with the physicians and whoever else is on your team. And then once you're healed and back to your sport, let's talk about picking back up where you were and that similar eating pattern of fueling for your sport. But right now it's going to look a little different.
That's great. That's great advice. I would encourage you guys to reach out if you have any other questions. And we are really excited to get back to our rhythm of Coffee Kids and Sports Medicine. Thank you, Taylor and Dr. Gill, for your expertise and your very wise words and helpful tips today. And we look forward to more, both on-demand and live versions. We hope to have another live version in the fall, so please check your email and keep your eyes peeled for our next topics, and don't hesitate to reach out for any topics of interest. We want to be sure to educate you guys on things you're interested in learning about. And hopefully to also look out for opportunities to be a guest here live. We're always changing. We don't know how many we'll need to accept, but please, we look forward to seeing everyone in person as well. So thanks again. Thank you guys for your time, and appreciate everyone. Thanks.